Hey everyone, and welcome to our deep dive into a crucial topic in orthodontics. A comprehensive overview of two common types of malocclusions, deep bite and open bite. We will explore their definitions, causes, clinical implications, and various treatment mechanics, highlighting the distinctions between dental and skeletal origins. Deep bite correction. A deep bite is a vertical malocclusion characterized by an excessive vertical overlap of the upper front teeth over the lower front teeth when the jaws are closed. A normal overbite is typically around 2-3 millimeters, while a deep bite is defined as an overlap greater than 4 millimeters. This condition can stem from either dental factors, such as the over-eruption of anterior teeth, or skeletal factors, involving vertical jaw relationship problems. Untreated deep bites can lead to a range of issues, including lingual tipping of incisors, loss of anchorage for orthodontic movements, temporomandibular joint, TMJ, dysfunction, trauma to the palatal gingiva, and excessive tooth wear. Therefore, early and accurate diagnosis is crucial for effective intervention. Several methods are employed for deep bite correction, often tailored to the patient's age and the underlying cause. Incisor intrusion. One primary approach involves intruding, or pushing up, the over-erupted incisors. This can be achieved through various techniques. Utility arches, stainless steel utility arches, e.g. 101/16 0.22 inch, are commonly used to apply intrusive forces to the anterior teeth. Reverse curve of SPE arch wires. These arch wires are particularly effective for lower incisors, helping to flatten the curve of SPE and intrude the anterior segment. Intrusion arches. Techniques like the burrstone intrusion arch are designed to distribute force efficiently, preventing excessive tipping of the teeth during intrusion. To minimize the risk of root resorption, light, continuous forces, typically around 15-20 grams per tooth, are recommended. Incisor intrusion is generally a stable and effective method in adult patients. Molar extrusion. Alternatively, the bite can be opened by extruding, or bringing down, the molars. This approach is often preferred in growing patients due to better stability and adaptability. Vertical elastics. These elastics are used to apply extrusive forces to the molars. Bite plates. Anterior. Bite plates are appliances that prevent the anterior teeth from occluding, thereby allowing the posterior teeth to erupt and open the bite. This method is more effective in growing individuals as it leverages natural growth processes. Clinical considerations for deep bite correction. Accurate diagnosis is paramount to determine whether the deep bite is primarily skeletal or dental in origin. While incisor intrusion is effective in adults, molar extrusion tends to be more stable in growing patients. Patient cooperation, especially with the use of elastics and bite plates, significantly influences treatment success. Clinicians must also be vigilant for potential risks such as gingival recession, root resorption, and altered smile aesthetics due to over-intrusion. The choice of biomechanics must carefully balance stability, aesthetics, and function, ensuring that vertical corrections are precisely targeted to the underlying cause. Curve of SPE correction. The curve of SPE, the antero-posterior curvature of the occlusal surfaces, often plays a role in deep bite cases. Its correction is integral to achieving a stable bite, stepped curve. When there is a step between premolars and canines, but parallel tooth axes, correction can be achieved through either incisor intrusion or molar extrusion. Angulated curve. If teeth are on a curved arch, a reverse curve wire can extrude premolars and intrude incisors. This may necessitate space for leveling and differential mechanics to prevent incisor protrusion, with segmented arch wires proving beneficial. Class 2, Division 2 strategy. The treatment strategy for Class 2, Division 2 malocclusions, often associated with deep bites, varies with patient age. Growing patient. The focus is on intruding and protruding the upper incisors to free the mandible and encourage forward growth. WD. Adult patient, extraction, and segmented arch mechanics are typically employed to avoid round tripping and root resorption. It is crucial to avoid starting with straight wires in these cases, as it can lead to incisor protrusion and conversion to a Class 2, Division 1 malocclusion, which then requires retraction and may cause root resorption. Dental open bite. A dental open bite occurs when the anterior teeth fail to overlap vertically due to dental eruption problems rather than underlying skeletal growth discrepancies. This condition is most commonly associated with habits such as thumb sucking, tongue thrusting, or prolonged pacifier use. The primary issue lies with the positioning of the teeth, not the jaw bases themselves. Compared to skeletal open bites, dental open bites are generally easier to treat and tend to be more stable, provided the causative habit is successfully eliminated. Treatment mechanics for dental open bite. 1. Habit elimination. The cornerstone of dental open bite treatment is the elimination of the causative habit. Without effective habit control, the risk of relapse is significantly high. 2. Controlling vertical movement of molars. In cases where dental eruption contributes to the open bite, controlling molar eruption is critical. A high-pole headgear combined with a transpalatal arch can help prevent further vertical eruption of molars. 3. Segmented arch technique. A 0116 0.022-inch stainless steel segmented arch can be strategically used as an occlusal stop to control erupting molars, thereby preventing them from over-erupting and exacerbating the anterior open bite. 4. Reverse curve of SPE+. Anterior box elastics. The use of reverse curved arch wires in conjunction with anterior box elastics can effectively close anterior dental open bites. This mechanism works by intruding molars, extruding incisors, and blocking premolars from erupting. While this approach can yield fast and effective results, often closing the bite within 1 to 2 months, its success is heavily dependent on patient compliance with elastics. Furthermore, prolonged use beyond 2 months carries the risk of gingival recession and a gummy smile due to overextrusion of incisors. Skeletal open bite. In contrast, a skeletal open bite is rooted in jaw growth discrepancies, typically involving excessive vertical growth of the maxilla or mandible. This makes it a more challenging condition to treat and more prone to relapse compared to dental open bites. The main challenge lies in the critical control of the vertical dimension, as conventional orthodontic mechanics often prove insufficient because they rely on dental extrusion rather than true skeletal correction. Patient cooperation with elastics or other appliances also plays a significant role in the overall success of treatment. Treatment mechanics for skeletal open bite. 1. Molar control with headgear plus transpalatal arch. A high-pole headgear combined with a transpalatal arch can effectively control vertical molar eruption. If the transpalatal arch is positioned 2-3 mm away from the palate, the tongue pressure during swallowing can help intrude the molars, preventing further bite opening. 2. Segmented arch for second molars. A 0.022-inch stainless steel segmented arch, placed through the auxiliary tube of the first molar, can serve as an occlusal stop. This helps control the eruption of second molars before they reach the occlusal plane, thereby preventing the worsening of the open bite. 3. Reverse curve of SPE with anterior box elastics. Similar to dental open bites, this approach can be used for skeletal open bites. Reverse curved arch wires with strong anterior box elastics can close anterior open bites by intruding molars, extruding incisors, and preventing premolars from erupting. While fast 1 to 2 months, the relapse risk is high if elastics are not worn full-time, and prolonged use, 2 months, can lead to gingival recession and a gummy smile from incisor over eruption. 4. Molar intrusion with micro-implant anchorage, TADS. For true skeletal open bite correction, molar intrusion using temporary anchorage devices, TADS, is often indispensable. TADS provide direct skeletal anchorage, bypassing the need for heavy patient cooperation and offering a stable and effective means to manage vertical discrepancies. This is considered one of the most challenging but ultimately effective approaches for long-term control. Conclusion. Understanding the nuances between deep bite and open bite and their respective dental and skeletal origins is fundamental for effective orthodontic treatment. Precise diagnosis, tailored treatment mechanics, and diligent patient cooperation are all critical factors in achieving stable, aesthetic, and functional outcomes. The advancements in orthodontic techniques, particularly with the advent of skeletal anchorage devices like TADs, have significantly enhanced the ability to address complex vertical malocclusions with greater predictability and success. Understanding these methods is key to appreciating the science and artistry behind creating beautiful, healthy smiles. Thanks for watching, and we hope this video has helped you better understand this vital aspect of orthodontic treatment. So, the next time you see a stunning smile, you'll know the incredible science and artistry that may have gone into creating it. If you're a student interested in dentistry or orthodontics, we hope this video has given you a glimpse into this exciting field. Don't forget to like, subscribe, and hit that notification bell for more educational content. And if you have any questions, drop them in the comments below. Thanks for watching.